Good morning. I think Ocumel UK is a very exciting initiative, and I'm delighted to be here to give my full support. What I hope to do is to say a few words about each stage in the care pathway, ending up with a few words about the importance of research. But first I'll say a few words about ocular melanomas. And these are rare, affecting 7 people per million per year, more or less. Good for society, because it's rare, but not so good for those who have the disease, because the rarity creates special problems and challenges which we're trying to overcome here and now. Males and females are affected in equal numbers, and the mean age of presentation is 60 years. Now, there are many different kinds of ocular melanoma. Most occur inside the eye in a tissue known as the uvea. But then there are the conjunctival melanomas on the surface of the eye. And the conjunctival melanomas behave totally differently from the uveal melanomas. They behave very much like skin melanomas. And in both tissues, the way the tumor behaves depends very much on where it occurs. So tumors at the back of the eye in the choroid behave very differently from tumors in the iris. And in the conjunctiva, tumors near the nose behave very differently from those far away from the nose. So lots of different types of melanoma. And even when they look the same, they can be totally different from each other. As you know, all our cells are regulated by our DNA in the chromosomes, and cancer is a disease of DNA. The genes go wrong. And really, you've got 2 kinds of melanoma, uveal melanoma. I'm only going to speak about uveal melanoma from now on because of the limited time. There are those with mutations in the 3rd chromosome, chromosome 3. And these are highly lethal. Sooner or later, metastatic disease is going to develop in all patients who live long enough to develop such disease. Whereas if this abnormality in chromosome 3 is absent, then metastatic disease, spread of the tumor to the liver and other parts of the body, is extremely rare. There's been a debate as to whether the good melanomas and bad melanomas are totally distinct from day one, but I believe, and I've had some recent evidence to suggest that the bad melanomas evolve from the good melanomas over time. So what that would mean is that whether or not ocular treatment is life-saving depends on whether the ocular treatment occurs before the switch occurs or afterwards. And in some patients, this malignant transformation of melanoma occurs at a very early stage, and in others it occurs a bit later. In Liverpool, I moved to Liverpool from Glasgow in 1993, and that's when we started our tumor service there. And I moved from Glasgow because our patients were saying that they were traveling too far, and most patients were coming from south of the border. And Liverpool's in the geographic centre of the British Isles, and it's also very close to the proton beam unit at Clatterbridge Hospital, the only proton beam unit for ocular tumours. And that's why I moved to Liverpool. So last year we saw about 700 patients, and about 250 of these have an ocular melanoma. And we need these large numbers of patients. We need to focus this work so that we can focus expertise, we can focus experience, and also so that we can afford to have more staff, more nurses, psychologists, more equipment, more plaques, and also so that we can get data and tissues so that we can do meaningful research and understand what's going on. And happily, the same situation occurs in London, Sheffield, and Glasgow. And the reason is that in Britain, we have special funding directly from the Department of Health. And in Scotland, that occurs through the Scottish Home and Health Department in Edinburgh. And in England, it occurs through the National Specialist Commissioning Team in London. And we're extremely lucky to have this funding because eye tumors are not very lucrative for hospitals. We can't compete against cataracts that bring in lots of money to the hospital that subsidize the poorer specialties. But thanks to this special funding that we've got, we can focus our experience and our expertise. And in many other countries, they don't have that, so that most patients in Europe and in the States are treated by doctors who would only see half a dozen or maybe 20 or 30 patients in a year, and so they don't have the experience that it takes and whatever. So in Britain, as a group, we're very lucky here. Long may it last. Now, the results depend very much on the size of the tumor. And the size of the tumor depends on whether or not the tumor is detected at an early stage. Now, in Britain, most uveal melanomas are detected by optometrists, 2/3 of melanomas. Now, about a third of patients, 40% of patients, are asymptomatic when their tumor is detected by an optometrist. And good for the optometrist for doing that. Well done. Because those patients get the best results. Relatively few of them lose the eye, and most of them keep driving vision in that eye. But in the symptomatic patients, about a quarter of symptomatic patients tell us that their melanoma was missed by the optometrist when they went to the optometrist with symptoms. And those patients have got a much higher chance, the majority of those patients lose the eye, as compared to only about 20% of patients who lose the eye if they're asymptomatic. It makes a big difference whether there are symptoms, and if there are symptoms, it makes a big difference whether the tumor is picked up straight away by the optometrist. Now, the patients don't know what treatment they're going to get when they fill in our questionnaire about how the tumor was detected, whether it was detected or missed by the optometrist. So we need to do more to educate our optometrists about how to detect these tumors, how to dilate the pupils, and look at the back of the eye properly through an open window instead of through a closed window, and so on. But now we reach the next stage, which is the referral process. Now, some patients are passed through the system very quickly, but quite a few are held up at one stage or another because the referral letter got lost in the post, or for one reason or another, or because the doctor wasn't sure of the diagnosis. And about 20%, 1 in 5 patients, waits more than 6 months to reach an ocular oncology service. So there's an awful lot that we are doing, that we can do, to try and expedite the process. Because to wait 6 months to go a few miles from your village to an oncology center is too long. So, as I said, one of the problems is diagnosis. And the problem occurs because there are so many different kinds of tumor. There are neoplastic tumors, where you get a proliferation of cells, bad flesh. And then you have the non-neoplastic tumors, such as hemorrhages, abscesses, and other kinds of swelling. And then the neoplastic tumors with bad tissue growth can be benign, malignant, primary, secondary. And each kind of tumor has got lots of different manifestations. So, and because they're all so rare, it's very difficult for optometrists and general doctors to remember what they learned at school, at medical school, when they passed their exams, because our memory fades with time. And the problem is that if you try to look at an atlas to make the diagnosis, there's so many pages that by the time you don't know what page to open because you don't know what's wrong, and you don't know what's wrong because you don't know what page to open. And by the time you found the page, the patient's probably got fed up waiting outside and gone back home again. So we need a sort of GPS, a sat-nav, to help people diagnose tumors they're not even aware of, that they've never even heard about, even in medical school, because it's too small print for most medical textbooks. And so I've been working on such a sat-nav that works on my iPhone and on my iPad. And the concept is different, that the perspective is from the user's point of view and not the expert's point of view. So instead of listing things according to diagnosis, they're listed according to color and shape and so on. And like that, it seems to be easier to make a diagnosis. So once I've made a diagnosis, the next thing to do is staging, so that you can see how severe the disease is, what the future prospects are, and all the rest of it. Now, all around the world, cancers are staged according to the tumor, node, and metastasis system developed by the UICC and the AJCC, American Joint Committee on Cancer. Now, it doesn't quite apply to uveal melanomas because lymph node metastases are very rare, and detectable liver metastases are also very rare at the time of diagnosis. Even if you do lots of scans, most of the seeds are not detectable at that stage. So we rely on the ocular features of the tumor, the primary tumor. That means the size, and there are various ways of categorizing the size, and ultrasonography is excellent for measuring the size. Whether or not the ciliary body is involved, the ciliary body is a muscular tissue surrounding the lens that changes the focus of the lens. And whether or not the tumor is going out of the eye. And these three features form the basis of the TNM staging system. And recently it was updated to the 7th edition, and we were very much involved in contributing data to this group. We need lots of data on lots of patients in order to get meaningful predictions. But the problem is that the clinical features are only the tip of the iceberg. They only tell a small part of the story. They only say how long the tumor has been there. You also need to know the genetic type, whether or not it is capable of sending seeds around the body. And you also need to look at the histological grade of malignancy to see how fast the tumor cells are reproducing, are increasing and multiplying. You can see them dividing under the microscope. And so you need to look at as much information as possible. And we've developed a system that works on the internet for combining all these different types of information. So here's a hypothetical 60-year-old lady with a medium-sized tumor, and this is the prediction that would occur if we relied only on the clinical findings, on ophthalmoscopy and ocular ultrasonography. She would get a precise prognostication telling her this is the normal survival probability. If she didn't have her tumor, at her age 60, she'd have a 9 in 10 chance of surviving 10 years. But because she's got her melanoma, she's got a 6 in 10 chance of surviving 10 years. So if you take away that 1, so 9 minus 6 is 3, so she's got a 3 in 10 chance of dying of her melanoma. But if you do a biopsy, or if the eye is removed or whatever, and the tissue examination shows that there's no loss of chromosome 3, and the histology is not too aggressive, then her life expectancy is exactly the same as the normal population. It's as if she never had her tumor. Whereas if the biopsy shows a mutation in chromosome 3 and there's lots of cells multiplying and everything, then she's got a terrible prognosis. So a tumor may look the same, but may have totally different behavior. And that's why it's important to get as much tissue as possible, as much information as possible. Now, if the eye is removed or if the tumor is removed, then it's very easy to get tissue. But if we're treating with radiotherapy or laser treatment, whatever, we have to take a sample, then it's more difficult. We either can cut a wedge out with scissors, or else we can suck a little bit of tissue out, either with a needle or with what we call a vitreous cutter, with a guillotine at the end of it, and so on. But that's difficult. It can cause complications, and it's difficult to get enough tissue. And that's only part of the story. There's also laboratory methods. There are lots of different tests that can be done. The more the better for diagnosis, and nowadays for prognosis. Not just looking at how many cells are multiplying, but also looking at the genetic abnormalities, etc. And these are difficult tests in laboratory, especially on very, very tiny samples. And as I said, it's not just the expense, but the inconvenience for the patient, the risk of harming the eye, causing inflammation, and the risk of failure. And so this is a very controversial area. It's a new area. It isn't really standard practice in most eye places around the world, eye tumor units around the world. It's becoming routine more widely, but it takes time, and it's still a debatable issue. Now we come to ocular treatment. Why do we treat the eye? Well, first of all, in the hope of preventing spread if it hasn't occurred. We're never quite sure whether it's occurred or not, unless there's detectable disease. Secondly, to conserve vision. And thirdly, to avoid pain. If you don't treat the eye, eventually you get a big mass, inflammation, all sorts of things. And there are three key ways of doing it: radiotherapy, phototherapy with light, laser treatment, hot laser or cold laser, and surgical, removing the tumor or the eye or whatever. And each of these there are different variations and combinations. And the more facilities that we have available, the better, because the more we can mix and match and tailor the treatment for each individual patient according to what the patient's priorities are, and so as to increase the chances of killing the tumor while decreasing the chances of side effects. And in Britain, we're very lucky that we have more facilities available to us than anywhere else in the world that I can think of, and I'm not exaggerating. Either they don't have proton beam, or they have proton beam but they don't use plaques, or if they have plaques they only use one kind of plaque, which gives radiation all over the place, or else they don't have the anesthesia that we have to give hypotension, to remove the tumor surgically. Vicky, isn't that true? Mention any country and I can tell you what the limitations are in that country compared to Britain. I think our NHS funding creates a lot of opportunities and gets rid of a whole lot of obstacles that trouble other people around the world. Now, the next stage is to assess the results. We need to assess the results to see if we're doing well, to see if we should abandon bad treatments, to see how we can improve good treatments, to be able to advise patients what their chances are so that they can decide what they want. So there are objective results and subjective results. The objective results are how often we save the eye or the vision, how often the tumor comes back if we do save the eye, survival. The subjective results are whether patients can do what they want to do, whether they can read, whether they've got good enough vision for reading, driving, walking in crowds, whether their eye is comfortable, whether they're happy with their appearance, whether they're worried about their future health or worried about recurrence, and quality of life generally. And it's important to measure all these outcomes in all patients in perpetuity, if possible. But you might like to know that here's the quality of life of our patients, 1,500 patients that we've been studying. And the bright colors are good quality of life. 7 is excellent, and 1 is very poor. And only a tiny minority of patients complain of a poor quality of life. From our studies, either they've got systemic disease or their poor quality of life is due to other causes, other illnesses unrelated to their eye. So the British patients are known for not complaining very much, but the quality of life studies bear that out and show that most report a good quality of life despite having had an eye melanoma. But these results are much more meaningful if we correlate them with baseline features. For instance, there's an old diagram I found. The chance of saving the eye vary enormously according to the size of the tumor. And then a lot of complications take time to develop, especially after radiotherapy. They can take years to develop. So you've got to take account of follow-up time. And thirdly, it also depends on what statistics you use, because you've got competing risks. I'm in competition here. You can't die of melanoma if you've already died of old age. It sounds silly to say that, but a lot of doctors are fooled because they're not taking that into account. It's not their fault, it's the statistician's fault for not educating us properly. For instance, we tend to use Kaplan-Meier analysis. And this curve represents the melanoma mortality. And the ticks are patients who are excluded because of non-melanoma deaths. Now, of course, if you exclude all the patients who die of old age, you're only left with the ones who die of melanoma. So obviously, this method is going to exaggerate the melanoma deaths. So this gives the impression that the older you get, the more you're likely to die of your melanoma. And a lot of doctors, tell me if I'm wrong, would look at this in the BMJ and they would interpret that for what it is. And they might concoct arguments that when you get old, your immune system diminishes and so you die of your melanoma. But if you use a statistical method that adjusts for competing risks, like what we use here, you've got the all-cause mortality of the general population, the all-cause mortality of the melanoma population. It gives the opposite results. It takes account of the fact that there are many patients who are saved by the bell and never get the metastasis from the melanoma. And so with age, the chance of dying of melanoma are much less than in younger people. So you've got to understand a bit about statistics. And then also, a lot of this work is very labor intensive. And if we didn't get special funding from the Department of Health, this would all be impossible. For instance, to look at patient-reported outcome measures, we send all our patients a questionnaire, a 70-item questionnaire on the anniversary of their treatment. And we're sending out, Nicola Longrig is sending out more than 100 questionnaires every month. So every month, 100 times 70 is 700, is 7,000. She's got to put in 7,000 bits of information every month, on top of chasing the ones who don't reply and getting the consents and making sure she doesn't send any questionnaires to patients who've died because it upsets the relatives, understandably. So it's a lot of work. So why do we do all this? And what's the other aspect of care is counseling. And different people provide different counseling in the team. That's why we've got a multidisciplinary team. The ophthalmologist, as an ophthalmologist, I would educate the patients on the anatomy of the eye, the pathology, what would happen if we don't treat the tumor, then speak about the different therapeutic options, the chances of success, the chance of complications, and what aftercare is going to be necessary. And since 91 or 92, I've always given, that's me in my former life, given patients an audio cassette of the recording of what I've told them. And recently we did a study which showed that many patients no longer have a cassette player, not even in their car. So now we give them all a CD. which is much more labor intensive, but we do that. Nicola burns the CDs and sends them out to patients. Except now we're not allowed to give patients the CDs unless it's password protected, and we have to give them the password at a different time from when we give them the CD. It's okay if we write everything down on a piece of paper and the paper gets blown away in the wind, no problem. But because it's on a CD, apparently we can get fined £500,000 if it gets into the wrong hands. So, but we've overcome that obstacle, and we're giving patients CDs of what we're telling them. And we're lucky enough to have this big TV screen where we can put a patient's photo of their actual tumor, and they can see it in 3D, and they can imagine where it is in their head, and it helps them understand. The nurse would look after housekeeping things, like how long they stay in hospital, how they might feel, what drops to take, how to take the drops, how to instill them, how not to instill them, what aftercare, and to give them support, telephone helpline, all sorts of other things. And the psychologist would see the patient, screen them to find them that they're vulnerable to an excessive amount of stress or depression, and just takes appropriate action and keeps in touch with them, provides counseling and so on. So it's a multidisciplinary team. But in addition to the face-to-face counseling, there's also a blue book, a 70-page book with lots of tips and tricks how to survive your care pathway through the hospital, copies of letters to the GP get sent to patients, information sheets, a patient website, which we're updating at the moment, is another website, and another one I'm developing with more in-depth discussions. And with this, it's possible to download the blue book and also all the patient information leaflets that we give to patients. So really, patients have got no excuse for not knowing something, really, because it's out there. The excuse that they have is that they're not aware it's out there. And hopefully this group will help patients to know what's available, where they can get information, what information is good and what information is unsafe. Then there's follow-up to detect any problems and treat them, to counsel patients, to perform quality control studies. And this can be done either in the eye tumor clinic or the patient's local hospital. And what we've started recently is a nurse clinic for patients who don't need to go to a specialized clinic, patients who are not happy to go to the local hospital. And if it's safe for them to see our nurses, they see our nurses. If the nurses are not sure about anything, then they call a doctor. And this has become possible thanks to this special camera, which gives wide-angle views of the back of the eye so that it's absolutely foolproof to see whether the tumor is growing or shrinking. Now we come to systemic screening. But there's no consensus as to who should be screened and when and how often and for how long and with which method. But as an eye doctor, I leave it to the general oncologists, and they're going to have plenty of opportunity to discuss these things with you today later on. I'm not ducking the issue, but I'd be very taken aback if they were to tell me how to treat an eye with radiotherapy, and I expect it's the other way around. Same with systemic treatment. Amazing, exciting treatments coming along, and I'll leave it to my colleagues to share that with you. Finally, a few words about research, teaching, and audit. Absolutely essential. If we didn't do all these things, we'd still be applying leeches and would still be removing eyes of all patients with melanoma, no questions asked on day one, and would still be giving patients totally the wrong information. Whereas thanks to research, things are progressing so rapidly, really exciting. And teaching, once we've learned something, if you're a surgeon, you've learned a little tip, little trick, unless we share it with others, and unless we learn from others, we're going to be stuck, we're going to stagnate. And luckily, London, Sheffield, Liverpool, ourselves, we get together once a year. And we've got a meeting in November, and on the agenda we're supposed to speak about, we're preparing to speak about, and we're looking forward to speaking about an unusually successful case or an unusually disappointing case. And also we're going to share with each other our successes and our failures. And it's great that we're able to do that, that we're going to meet, that we are already meeting. We've been doing this for several years now. Whereas in other countries, in France they've got their act together, but in several other countries they keep very apart from each other. They're more in competition with each other. Whereas here in Britain, I think it's a friendly rivalry that we all want to do very well, don't we? But it's not like other places where it's not a benevolent kind of competition that there are in some other countries that we're aware of. In Britain, we're lucky that we get on well together. So, audit is doing quality of control of our results. And apart from the clinical research, we've also got a team of scientists working in our laboratory, and the same in London, they've got their team, and in Sheffield, they've got their team. But speaking for ourselves, you can look at our website here. The only way that we can continue with this research is thanks to patient donations, because the grants are difficult to get and there are gaps between one grant and another. And if it weren't for our research fund, we'd have to let very skilled scientists go, and then we'd have to start again from scratch the next time we got a big grant from the CRUK or whatever. Whereas our in-house grants, totally from patients, enables us to keep up the momentum and to develop from one year to the other. So that's absolutely great. So what do we do? At the end of the day, we publish papers in journals, we give talks at conferences, in hospitals, optometry meetings, write chapters in books, show posters at conferences. Conferences are really important, and many of us have official duties in these conferences to help them to come about, to select speakers, to prepare agendas, timetables, and so on. We spend a lot of our time doing this research. And here are some of the developments I've been involved with over the years. And thanks to these developments, the care that patients have received, that are receiving, has profoundly changed the past 5, 10 years, 15 years. Not only in Liverpool, but in London, Sheffield, many other places. And this would not be possible without the help of patients like yourselves. Not only financial help, but also giving consent for the use of your tissues for research, your images, your data, your response to questionnaires, your participation in clinical trials. So it's very much a team effort, doing things together. And to conclude, I'll quote Leslie Kirkpatrick, who unwittingly wrote in her email some time ago that only by working together can we move forward. Those are her words, not mine. And this organization is going to help us to work together. It's going to give a voice loud enough for people out there to hear. And it's going to really expedite improvements in the United Kingdom. So I'd like to thank my co-workers, clinical co-workers, basic science co-workers, and thank you for your attention.
Do you know approximately how many times you try to biopsy and fail to get the adequate result?
Our failure rate, we've got Michaela, who's studying that at the moment. Failure is about 30%, which is very high. We can very easily get it down to 1% by not biopsying tumors less than 5 millimeters in thickness. But although it's more difficult to biopsy small tumors, it's just as important. So we tell our patients what the chances are of success, and if they accept those chances, we go ahead and try the biopsy. Yeah.
Bertil, you've done all this amazing work on the genetics of melanoma in the eye. What is your experience of what happens in distant disease, for example, in the liver or lymph nodes or other sites?
Yeah, we've got Andy Dodson, who is working on precisely that, comparing the primary melanoma with the metastasis and looking at genetic changes in both of them. And hopefully, by doing that, he'll find out more about what drives the metastatic process. Because what we're aiming for is a personalized treatment, that we give one kind of systemic treatment to one patient, depending on their genetic profile of that tumor, and a different kind of treatment to another patient. And that's what we're really aiming for. Mm.
Do you know what is the likelihood of the current budget cuts in the NHS affecting your future work?
Well, we're really lucky that we've got this funding from the National Specialist Commissioning Team. But I know that there are threats in that area. And how long it's going to continue, I don't know. They might reduce the number of services that they provide, the number of types of diseases treatments they sponsor. Hopefully, ophthalmology will continue to be sponsored. But next year is when we're going to hear which services are going to continue and which services are going to stop. And we're very lucky, aren't we? Because when we speak to other specialists, they tell us all sorts of terrible stories about cutbacks and loss of staff and loss of equipment, loss of clinic space, loss of theatre time and all the rest of it. And many are retiring because they can't cope with the stress of not having the facilities they used to have a few years ago. But happily, until now, in ocular oncology, thanks to this funding, we've been doing very well. We've been going through a golden era, I think.
Yeah, we have been very protected. I bet this year is the first time they've cut funding by 12%.
That's right.
That's minor compared to other services in the NHS that aren't nationally commissioned.
Yeah.
Just a comment on that, really. The vociferousness is speaking about what's needed. The visibility of a problem will have a major impact on what will continue. So what's happening here today is a really important tool in ensuring that these things don't disappear.
That's right.
Although, if you look at the overall funding level in the UK, actually, in spite of all the other cuts, for research, the funding has remained amazingly stable. It hasn't grown as much as we would like it to, but it hasn't dropped either. So that's true for all the big funders, Cancer Research UK, MRC, Wellcome Trust, and so on in the UK. So I don't think that the specific work that Professor Damato is doing is going to be at risk from this perspective.
Thank you.